about treatment for more conventional CRPC, the metastatic CRPC, and thinking about sequencing and what's new in the field. Again, the same disclosures, and this is what I'm going to try to do, talk about the spectrum of CRPC, review currently available options, discuss a bit about what we're learning from molecular biology of cancer, build on Mitch's comments, and about how that's getting translated into potential therapeutics and molecular targets that are associated with those. So when you think about disease states in prostate cancer, this is sort of a simplified diagram that helps us a little bit organize our thinking. This is localized disease. This is what we've just been talking about, non-metastatic castration-resistant prostate cancer. This talk is really going to be focused on metastatic CRPC. Now in this space, as you're going to see in a few slides, we have a number of agents. There's been quite a bit of progress. I would say in the last 2 or 3 years, we haven't seen new agents. So there was this big burst of activity between 2010 and 2016 or so. In the last couple of years, we are waiting for the next generation of molecularly driven trials. But the complexity of the disease has increased dramatically. So my talk is going to be largely about how you treat patients who are sort of classic mCRPC, which means metastatic disease previously treated with hormone therapy. But that's not really what we're beginning to see anymore, because these patients are arriving in our practice having been exposed to early abiraterone, having been exposed to early docetaxel. With this non-metastatic data with apalutamide and enzalutamide, we're going to start seeing some of these things. So it's a rapidly changing field, and I don't yet have a talk on what the heck to do with that, but maybe we can discuss that in our Q&A session. This is what the worst of this disease can look like. Obviously, predominantly a skeleton invasive disease. But the worst prognosis patients develop liver metastases. You know, in our practice, we're seeing more of these liver metastases patients, particularly after multiple lines of therapy. So this is no longer an extraordinary scan as it used to be. Liver mets are uniquely poorly prognostic. We often report visceral metastases as a classification, but just as an aside, lung mets alone are not so bad. Prognosis is typically similar to bone met patients, but liver is different. So as we think about how we might personalize our therapeutic approaches in the context of all these therapies that we have available, I find it useful to think about what are the basic building blocks of a personalized strategy. And obviously, we need multiple therapy options, otherwise there's nothing to personalize. We need real heterogeneity in the disease and in the tumor response to various treatments, and we need an ability to figure that out prospectively with some sort of testing. And then we also need at least some opportunity to apply non-standard treatments to the disease based on some of the molecular ideas that Mitch introduced earlier this morning. This is a summary table of what I'm going to talk about for the next dozen slides or so. These are the 6 approved agents that have been shown to extend survival in prostate cancer. So you can tell that Dan and I were particular masochists. We entered the field before there were any drugs that extended survival. And it's been really an exciting ride to be a part of many of these projects. Dan, by the way, was the lead investigator on one of the 2 initial trials that demonstrated a docetaxel survival benefit, the very first survival benefit ever shown in metastatic CRPC, and those are exciting days. But we've had docetaxel approved since 2004. Then we have 1 immunotherapy, sapolacel. I'm not going to talk much about that in the interest of time. A second chemotherapeutic, cabazitaxel. 2 androgen signaling inhibitors. I don't have mechanism slides in this talk, so I'll just say by way of introduction, abiraterone is a potent inhibitor of steroid synthesis. It works on the ligand production side. The beauty of it is that it inhibits the enzymes that produce androgens wherever they may be. So it's not just a testicular inhibition, but it works in the adrenal glands, and probably more importantly, it works in tumor stroma and tumor cells, which can also produce their own androgens, which is particularly sinister. Enzalutamide is obviously, as I alluded to earlier, an androgen receptor blocker. Doesn't tackle ligand production, and radium-223 is an alpha-emitting radiopharmaceutical. All of these agents have an OS benefit. Some of these agents have also a demonstrated progression-free survival benefit. The indications are summarized here. Very quickly, I'm going to show you the core primary endpoint data for several of these agents. So this is enzalutamide as it's most commonly used now, which is the pre-chemotherapy setting. The PREVAIL trial of 1,717 patients with metastatic, asymptomatic, or minimally symptomatic CRPC patients. Placebo-controlled comparison. By the way, the largest metastatic CRPC trial ever carried out. You can see on top the progression-free survival significantly improved from a median of 5.4 to a median of 20 months, and overall survival 31 versus 35 months. Now, just to put this OS in perspective, and this can be true for some of the other studies I'm going to discuss. When we got started in this field, the OS of a metastatic CRPC patient was 12 months. Part of that difference is due to stage migration. We treat earlier, we're more vigilant, so it's not all the drugs that we've introduced, but a good chunk of it is the serial use of multiple agents that extend survival, and that's really gratifying. The other thing I'd want to say is that these patients end up getting lots and lots of drugs that alter survival. So when you study drugs early, like the PREVAIL trial or even the SPARTAN and PROSPER trials I discussed earlier, it's a challenge to show an overall survival advantage when you've got 3, 4, 5 lines of therapy following progression. This is abiraterone. This is Chuck Ryan's study, Cougar 302, also in the pre-chemotherapy setting. One key design difference is because abiraterone uses prednisone as part of the treatment regimen, the control arm included prednisone. It wasn't just a pure placebo. And prednisone has a bit of activity in prostate cancer. So you can see the median progression-free survival in the control arm of PREVAIL was about 5 months. That's placebo. Here was about 8 months for abiraterone, for the prednisone control arm. For abiraterone, it was a 16 months hazard ratio of 0.53, a significant impact on progression-free survival, and a pretty similar outcome with regard to overall survival between abiraterone and enzalutamide, both positive results. How do these drugs work in the context of one another? This is something that comes up in the clinic all the time. I don't expect you to look at all these numbers. The message of this table is that they don't work terribly well. There is some activity for abiraterone after enzalutamide and some activity for enzalutamide after abiraterone, but it is much, much lower than when the agents are used frontline. This is a study from Heather Chang from the University of Washington who looked specifically at enzalutamide activity by prior therapy, and this is from 7 institutions from routine care, retrospective analysis collected from real-world data. And so you can see if you just focus on, let's say, this column, which is a PSA response of greater than 30%. Patients who are not pretreated with either Abi or docetaxel, about a 67% response rate. Prior Abi, only a 28%. Prior chemo, 43%. Prior Abi and chemo, 24%. So that gives you kind of a rough sense of how much response you're giving up by pretreating patients. Radium, very briefly, is an alpha-emitting radiopharmaceutical. It's distinct from strontium and samarium and other agents like that emit higher energy particles. These are relatively large particles that are heavy travel, only a few cell diameters before they deposit their energy and basically get trapped inside a cell nucleus. They are bone avid, so this is a bone targeting therapy. And in the Alsimca trial, which randomized symptomatic metastatic patients who were either chemo pre-treated or were chemo ineligible, radium was shown to improve overall survival and delay skeletal related events as well. The difference was 11.3 versus 14.9 months for overall survival. Radium is indicated in bone predominant disease. Low volume lymph nodes are okay, but visceral metastases or high volume lymph nodes are not indicated. And it should not be prescribed in combination with abiraterone, where recently we've seen data to suggest an increased risk of fracture and death. Now, chemotherapy remains the mainstay of treatment for CRPC, and I think it's actually going to have a bit of a resurgence as we use our novel hormonal agents earlier, and CRPC may again become a truly hormone-resistant state as we evolve practice. The first agent to show an overall survival advantage was docetaxel. This is Ian Tannock's study that used docetaxel alone. Dan's study included estramustine in the combination, and that combination is no longer in use, but very similar results from both studies. Docetaxel was compared to mitoxantrone and prednisone, which at that time was a standard of care based on its palliative benefits, and showed an improvement in overall survival, as shown on this Kaplan-Meier plot with a hazard ratio of 0.76, but also improvements in things that we care about, like pain response, PSA response, quality of life response, and so forth. Fairly low measurable disease responses with docetaxel. Cabazitaxel was a taxane designed specifically to address docetaxel-resistant disease and was studied in the post-docetaxel space, again compared to mitoxantrone, demonstrating both an overall survival and a progression-free survival advantage. Numerically, these are shown here in this table. The magnitude of differences are roughly similar to what you've seen with docetaxel over mitoxantrone. So how does chemotherapy work in the context of these new hormonal agents? Again, these are small retrospective analyses, and I'm not going to focus on individual numbers, but just showing this to you to make the point that the activity of chemotherapy is not too different whether you've had prior enzalutamide or abiraterone or haven't. You could say the response rates are a little bit lower, but they're not discernibly so. So that's helpful for us to know that these newer agents are not getting in the way of use of chemotherapy. And it's a reasonable question to ask, because although these are completely different classes of agents, there are actually some potential resistance mechanisms that could overlap between chemotherapy and high-potency hormonal agents. So it's gratifying to know that we can still use chemotherapy even in the context of these newer drugs. Same story for cabazitaxel. So my sort of one-slide summary on the status of chemotherapy: docetaxel remains the standard of care and remains active in patients despite ABI and ENZA treatment. Cabazitaxel is a standard second-line treatment. I didn't have the time to show you the data, but cabazitaxel has been compared to docetaxel in the frontline setting and yielded very similar results. So it didn't beat out docetaxel for the frontline status. It could be used in selected patients if there is a particular toxicity indication to choose cabazi over docetaxel. And based on those data, when we use Kabazi, we've moved to the 20 milligram per meter squared dose, which typically doesn't require growth factor support and yields the same survival as the original 25 milligram per meter squared dose. So this again is a summary slide of the data that I've just shown you, put together a little bit differently. You can see which drugs were studied with prior chemotherapy, what the comparator was, and the hazard ratios for OS. I think the hazard ratios for the newer hormonal drugs do stand out a little bit against the backdrop of the 0.75 hazard ratio for everything else. How do we sequence these agents? Now this is really not an answerable question, particularly in the context of patients being increasingly heterogeneous in their prior treatment history. This is my basic approach to the perfect average patient who hasn't had anything and who can tolerate everything and wants everything and can afford everything. But obviously in real life we vary quite a bit from this. Generally speaking, if we use CYP-T, we try to use it early. It appears based on retrospective data that the benefits might be greater when used earlier. We tend to use enzalutamide first. That's an institutional bias based on the fact that we've worked with enzalutamide since the phase 1 study, and you got to pick one, so we picked that one. But I think the world is 50-50 between Enza and Abi first. We can actually ask you guys, what's your first, raise your hand if your first agent of choice amongst the hormonal agents is Enza. What about Abi? Okay, so California is like 60-40 Abi. That's probably because of UCSF. I don't know. Maybe not, but it's kind of like this. One time I was in a debate with William O. in Switzerland about this question, and I was very convinced that I won that debate hands down, and the audience was stone cold 50-50, and this was like 3 years ago. So, you got to pick one of these agents. After patients progress on a hormonal agent, really docetaxel should probably be used next. The response rates to the second hormonal agents are relatively poor. In practice, sometimes we violate that recommendation because some patients really would prefer to try another hormonal agent, and we can talk about the ARV7 assay as a tool for that in the Q&A. We then typically use cabazitaxel, and I tend to use radium towards the end of my armamentarium, although some patients can't tolerate 2 lines of chemotherapy and so forth. I'm going to skip ahead here, and these are also my non-scientific tables of factors that might lead you to choose one agent over another along the way. And the Tom invented symbols here. The up arrow means I'm more likely to use that agent. The down arrow, less likely. The equal sign means that factor doesn't influence my thinking, and an X means you really shouldn't be using that agent. And so here are some clinical features. Bone predominance, CYP-T is not a drug for visceral disease. Radium is clearly indicated for bone predominant disease. All these other agents work regardless of site of disease. Visceral Mets is obviously the opposite, and radium is clearly contraindicated for visceral Mets. Galloping disease is not like a real thing that anybody's defined, except we see it in practice all the time. These are the patients whose disease is moving really quickly and you're worried about them. And CYP-T is not a good drug for that. Neither is radium. We used to think that these patients have to get chemotherapy, but the reality is that responses to Abi and Enza are rapid, and I don't let that influence my thinking in terms of the choice of drugs. Low PS might be an indicator for a hormonal agent over chemotherapy. Presence or absence of pain, CYP-T doesn't have a pain indication, but really all these other drugs have some pain benefit. Prior therapy, this is sort of self-explanatory. I've already alluded to that. And then, of course, there's some histologic variance. There's small cell, and that's a completely different thing, treated with platinum etoposide. And then there are these intermediate atypical cancer, aplastic histology, of aggressive, low PSA producing, viscerally attracted prostate cancers. We don't really know what to do with those. There are studies that have included carboplatin in the chemotherapy for those patients, and we tend to do that. But they are ill-defined and not very well researched. Now, I'm going to talk a little bit about biomarkers in the time I have remaining, and I think Mitch alluded to some of these already. I would think that we actually have, technically, we have one biomarker that is clinically useful now, and that's microsatellite instability. Pembrolizumab has a tumor agnostic indication based on microsatellite instability. Unfortunately, in prostate cancer, that's a rare event, probably 2 to 3% of patients. But when one sees that, one can certainly support the prescribing of pembrolizumab. Others are still really allocation to investigational agents, and DNA repair deficiencies of various sorts, as you heard earlier, are probably the most important abnormalities that lead to allocation to clinical trials. There's a ton of clinical trials of PARP inhibitors. Now, you saw the most recent table from the Quigley paper. I have my favorite figure from a 2015 paper from Robinson, which is a very similar figure. It's a map of genomic alterations. Both of these papers, if you want to know anything about the biology of metastatic CRPC, these are really great papers to spend a little bit of time on. This Cell paper, Robinson, and the Quigley paper that just came out. This is my favorite figure, so I'm going to take 30 seconds to walk you through it. What you see here is each column is an individual patient, so it's actually a patient-level map. And then each row is a genomic alteration. They're color-coded, and you can't see on this slide, but the key for that is here. The color coding describes whether it's a mutation, a substitution, what kind of mutation, is it an amplification, what kind of genomic alteration it is. And then they're put into groups, as Mitch showed earlier. And you can see real quick that AR alterations are incredibly common, not surprising. P53, the second most common. P10 and ETS fusions, that's the Tempus-ERG and similar genes, super common. And then you've got this huge number of different things that might be targetable with PARP inhibitors, with PI3 kinase inhibitors, with BET bromodomain inhibitors, and so forth that we need to work on and think about. Up here is the mutational load, and as discussed earlier, for the most part, it's relatively low, except for this small tail end of the hypermutated patients. These are probably the PD-1 inhibitor candidates that when you see that, you think about. Just very quickly, a little bit of data on from clinical trials that show why this is interesting. This is the original paper that reported that PD-1 inhibition response may have something to do with mutational burden. And this was a study done in colorectal cancer patients as well as some non-colorectal cancer patients. It's not a prostate cancer study. But you can see here biochemical response that's color-coded by brown versus blue versus black. And the brown are mismatch repair proficient patients, so patients without this particular DNA repair defect. Their cancer just kept growing. Whereas those that had DNA repair deficiency of this type had a high probability of response to PD-1 inhibitors. And that's kind of what's been exciting about this. At our institution, Julie Graf has done a study looking at pembrolizumab plus enzalutamide at the earliest point of progression on enzalutamide. So she's continuing enzalutamide. We think enzalutamide may increase PD-L1 expression, so there's some rationale for continuing it. And she saw a 19% response rate, including some, these are anecdotal slides, but they're kind of fun to show. These are two patients with liver mets that you could see baseline in week 24. This is responder 5, baseline in week 24, baseline in week 24. Pretty remarkable responses in the liver, which we don't see very often with other agents. So that study's continuing. The paper describing the first 27 patients is in the final stages of preparation. And we're doing a lot of work on biopsies to try to understand the biology of who responds and who doesn't respond. PARP inhibitors. Alex, do I have a couple more minutes to talk? Or? Okay. So PARP inhibitors are really interesting. Just by way of background, the PARP protein is really critical to repairing DNA damage, particularly single-strand DNA damage. So that's its biologic function in life. And it turns out that DNA repair has multiple redundant pathways in the human being. So just having loss of PARP or PARP inhibition in most cases doesn't have much of a therapeutic effect. So when these agents came along at first, the prevailing thinking in the field is that you need to combine them with a DNA damaging drug. So you need to damage the DNA, inhibit PARP, and that's the ticket. And that may very well be the ticket, and that's one strategy for using these drugs. But then we recognize that people who have either acquired or inherited DNA repair deficiency that's affecting their tumors, they already carry one hit, and you can do the second hit with a PARP inhibitor, and that can result in significant anti-tumor activity. And in prostate cancer, this is Johan de Bono's study published in the New England Journal a couple of years ago. Pilot study, 14 out of 16 patients with DNA damage repair deficiencies responded to the PARP inhibitor olaparib. This is the so-called TOPARP study. Another look at the data, not by response, but by progression-free survival. Progression-free survival was doubled roughly when you compared patients who did not have a DNA repair defect to those that did. It's pilot data, but it's exciting and interesting, and as a result of that, there's a ton of studies of PARP inhibitors underway in prostate cancer. As a result of this work, we've also recognized, and I think Mitchell alluded to this, that a larger than expected fraction of our patients with metastatic disease harbor inherited DNA mutations, and this is another great paper by Colin Pritchard in the New England Journal that I would take a look at if you're interested, that summarizes in detail an analysis of the types of defects that have been observed. This paper largely, and some of the other work in the field, has led to a new recommendation by the NCCN that men with metastatic prostate cancer be referred to medical genetics for potentially germline testing, because the risk is high enough that it may have implications for family. We're struggling to fully implement that with the genetic counseling resources that we have available, but that's something that we're working towards doing increasingly often. I think this is my concluding slide, where the field stands is that the DNA damage area is the furthest along. We have a growing body of evidence that double-stranded DNA repair defects are relatively common and are associated with responsiveness to PARP inhibitors and perhaps to platinum agents as well. And DNA mismatch repair deficiency, so-called microsatellite instability, appears to predict for immunotherapy response. Both of these strategies remain to be fully validated, and I think there's a lot more to come. Thank you very much for your attention.